Okay, everybody, we're going to get started here, and we appreciate you spending some time with us today. I am Lisa Salberg, and I am the founder and CEO of the Hypertrophic Cardiomyopathy Association. And today we are going to be bringing you a legislative update on the legislative initiatives that we have in the state of Rhode Island. It is our hope that by the end of this PowerPoint and comment from our esteemed panel that you will have an understanding of why it is that we believe that the Children's Cardiac Safety Act will be beneficial to the children and healthcare providers of the state of Rhode Island, as we have found in other states around the nation. Let me get you to our screen share because I thought we were already there. Okay, so a small but mighty state, Rhode Island. Thank you all for taking the time to join us today. So a little bit about what we're going to be doing. I'm going to tell you a little bit about the HCMA and introduce our panelists. We have Dr. Libin Wang coming to us from Boston and Tufts Medical Center, a longtime friend and HCM expert. And he's going to talk to us about the diseases that we are looking at for surveillance purposes through the Children's Cardiac Safety Act. I will be talking a little bit about HCM Awareness Day, the state report card we have for Rhode Island, as well as talking to Dr. Jan Berger, who is a pediatrician and is going to bring the pediatrician's point of view. And then we'll hear from Matthew Grant, a Rhode Island resident, who will share his personal HCM experience with you all. So without further ado, I'm going to start with explaining who we are. We are a 501c3 nonprofit organization providing education, advocacy, and support to patients, families, and the medical community related to HCM and all thick heart muscle disorders. It is our vision to be the best organization that we can be, to provide a voice for these patients who historically haven't had much of a voice. And we choose to use our voice to elevate not only the patient's experience, but the clinical care of those with HCM. And we have established 56 HCMA recognized centers of excellence in the United States. And we are working internationally to expand our reach through Latin America, Europe, Australia, and beyond, and Asia. So that is who we are as an organization. And I am not going to read the entire bio of our esteemed speaker, Dr. Libin Wang. Suffice to say, he has an expertise in genetics and in cardiovascular disease, specifically inherited cardiomyopathies. And it has been my pleasure to know Libin for many years now. And we began our journeys back in 1996. Well, I started the HCMA, and Libin left China to come to America to fulfill his dream of treating this patient population. So without further ado, Dr. Libin Wang, I hand the microphone over to you.
Well, thank you so much, Lisa, and thank you for HCMA and for this great opportunity to share what I know about hypertrophic cardiomyopathy and other inherited cardiomyopathies and channelopathies. As you all know, this is a serious condition that can cause serious problem, especially in children. The outcome can be devastating. And the hypertrophic cardiomyopathy means the heart wall, the heart muscle gets thicker. This is an inherited condition. I always tell my patients and my children patient that instead of a regular balloon, you have a thicker and stiffer balloon. This is very common and actually can affect 1 in 250 patients. We estimated that in the United States alone, we will have 1.3 million people that are affected by HCM. However, to this date, only a little bit more than 10% of patients are diagnosed. The major risk of hypertrophic cardiomyopathy is risk of sudden cardiac death, and especially in young people. And sometimes in young people, they may have stroke because of atrial fibrillation. Hypertrophic cardiomyopathy can cause heart failure symptoms, and that can be life-threatening and can be limiting. And while hypertrophic cardiomyopathy is the most commonly inherited cardiac disorders, but it is not the only inheritable cardiac conditions. And other cardiomyopathies, including dilated cardiomyopathy, arrhythmogenic right ventricular cardiomyopathy, Marfan syndrome, a lot of people may have heard it, and arrhythmias, including long QT, short QT syndrome, and Brugada syndrome. In young people, in the young population, the CPVT, the catalogenic polymorphic ventricular tachycardia can be also lethal, and other congenital diseases and abnormally originated coronary arteries, they can all occur in young people. It's estimated that in Rhode Island, it's actually true by my personal feeling, practicing in New England area, between 11,000 to 34,000 people in Rhode Island can be affected by inherited cardiomyopathies and channelopathies. And the symptoms can be subtle, and some kids, especially in children, they don't verbalize their concerns, and that's why I didn't become a pediatrician. But a lot of times, the kids will know, when you talk to the parents, they will notice they have shortness of breath, they have palpitation, they say, "Mom, Dad, my heart races." They may have chest pain, they may have pressure, they may squeeze their chest. The kids may feel tired, they cannot participate in sports as the other kids in their leagues. They may feel lightheaded. Sometimes they say, "I have a brain fog. I cannot concentrate on my homework." Kids may faint, may pass out, and kids sometimes give you say, "I just have muscle pain." If you have a routine visit, you may appreciate the heart murmur from them, and then when you dig deeper, you may say, "Oh, family members may have heart conditions." And the complications of hypertrophic cardiomyopathy and other inherited cardiomyopathies, channelopathies, the most lethal ones are sudden cardiac death, and kids may have arrhythmias that can lead to syncope or fainting spells. They may also have heart block that cause them to fainting spells. In young kids, they may have an infection. They may have endocarditis. I definitely have patients like that, and they may have limiting heart failure symptoms and need advanced therapy. And actually, HCM and other inherited conditions can be treated if we recognize them early and to prevent devastating outcomes.
There we go.
And most importantly, we want to prevent sudden cardiac death, and now this is feasible by life-saving internal implanted cardioverter defibrillator, we call it ICD. And heart failure symptom with advance of medicine, we have optimized medical treatment for children, especially, and we can provide transplant in children if we need it. Again, in young people, especially in kids, if they develop atrial fibrillation, although it's rare, but it can lead to devastating stroke and disabling symptoms. And medical therapy, anticoagulation, blood thinner that can prevent stroke, and we can have ablations to eliminate the rhythm for a long period of time. So inherited cardiomyopathy can come in different forms, but most commonly is autosomal dominant. Usually we get from either mom or dad. Kids may have 50% of chance of inherited hypertrophic cardiomyopathy or inherited conditions. I definitely had patients, mom and dad, they're both mild HCM cases. They didn't have much symptom, but the kids inherit, unfortunately, one gene from mom, one gene from dad, and develop hypertrophic cardiomyopathy in very young age and get a syncope sudden cardiac death and had the defibrillator at age 5. So that can happen too. So this really require our clinicians and colleagues to do our due diligence, to talk to the patients, their parents, and get detailed symptoms and family history to guide our diagnosis and therapy and prevent devastating outcomes.
Fantastic. Thank you for
Thank
that
you.
overview, Dr. Wang. And I wanted to take a moment to speak about HCM Awareness Day. We have had resolutions, proclamations, and laws passed in multiple states over the past 3 years recognizing HCM Awareness Day. And as you can see, our list is growing. And we hope to have this in every state. So we have an opportunity to take the last Wednesday of February every year and really focus on hypertrophic cardiomyopathy education and awareness. So thanks to all the states who've already participated. And we encourage more to do so. The Children's Cardiac Safety Act, the draft resolution can be, or I'm sorry, draft language can be found by using this QR code. What we are attempting to do is include cardiac questions in the well child examination, which would occur for all children under the age of 19. And under the ACA, well child examinations are reimbursed. And we are happy that that is the case. It is an opportunity for a family once a year to sit with their chosen healthcare provider and evaluate their individualized risks and identify what other testing and treatment might be necessary. We want to improve the professional development for healthcare providers with an online training solution. We've been utilizing this in New Jersey since 2015. It has been effective, it is cost effective, it is very inexpensive for us to run that system. And it helps make sure that all of the clinicians who are doing well child examinations understand the disease states that they are looking for, as many of these cardiac conditions were not well known even 15 years ago. So while most were going through their medical education, they may not have gotten the most up-to-date information on these cardiac diseases and their treatments. So this is an opportunity to refresh everybody. We also seek to improve the student athlete pre-participation physical to include family education and community education about signs and symptoms related to cardiac conditions. And we want to improve the ability of the healthcare provider to identify children and families at risk for genetic and congenital defects that could benefit from therapies and treatment. In the United States today, unfortunately, I can't get state-specific information at this moment from the CDC website, but I can give you annualized numbers. Between 2018 and 2023, the data that is within the Wonder database within the CDC indicates that 5,800 children and young people under the age of 24 have died from HCM alone. I'm not looking at all of the other disease states. Unfortunately, the system is not working 100% these past few weeks. And we will get you that information on the Rhode Island specific numbers. But 5,800 young people being lost to one of the disease states that we're looking for. And with proper management, we can expect that those with HCM should be able to live to the average age of mortality or beyond. So we're losing these kids probably because they're not being identified until autopsy. So what are the key virtues of this Children's Cardiac Safety Act? It's bipartisan. We know everybody has a heart. Republicans, Democrats, independents, communists, we all have hearts. We know that RFX in New Jersey have proven to be cost effective as we are proactive as opposed to reactive. It limits more costly procedures for the masses when we identify those families who are at risk for heart disease and we take appropriate action. And it could be as simple as an EKG. It could be as complex as a cardiopulmonary stress test and an MRI, but it depends on the disease that is present within that family. So we want to make sure that we're using the right test for the right person at the right time. We also want to promote cardiac wellness among our pediatric population for all children. We know how important it is to catch diseases early. We also know how important it is to get good habits started early. We have proven concept here in New Jersey without any ill effects on our pediatric cardiology community or our pediatricians. We are enabling parents to engage in a meaningful conversation with their chosen healthcare provider on really important matters while not wasting time on issues that don't impact that individual family. So by asking questions and providing those answers, healthcare providers can take the appropriate action. We know that life-saving happens when we identify people who are at risk for high burden diseases like HCM, long QT syndrome, ARVC, and other genetic forms of heart disease. I am now going to ask Dr. Jan Berger to comment a little bit on the American Academy of Pediatrics statement from 2021, which basically is a call to action on improving provider information on genetic and cardiac conditions in children. Jan.
Thank you, Lisa. Well, as Lisa said, the model language that we are suggesting has been vetted through the American Heart Association, but it also aligns with the American Academy of Pediatrics statement from 2021. As we know that the highest place in mortality, and it's interesting, the new data for 2024 just came out around where we're spending money and where people are dying in the United States. And unfortunately, the number one still remains heart disease. And we're better, and the American Academy of Pediatrics has noted we're better to start to address the high cost and the high mortality and the high humanistic impact of cardiac disease. Some people have asked, So does this take a lot more time? And the truth is, as a pediatrician, it doesn't. One of our important roles as pediatricians is to understand family history, family dynamics, developmental care, and behavioral care in both risk and growth. And in doing this during the annual visit or early on a first visit with a family, as you're making those attributions of family risk and individual risk, it takes a few minutes, and it doesn't have to be the pediatrician. Many providers have methodologies, whether it's online, whether it's in paper, whether it's the teammates or the provider, to really do a good job in understanding the family care. So again, not high cost, not high time consuming, but the AAP has been very clear that this is something that behooves everybody. Stroke and death, especially in children, can be avoided. Keeping families intact is an imperative.
Thank you, Jan. I wanted to bring to Rhode Island's attention that we have a report card at the HCMA, and currently Rhode Island is scoring a C. I see lots of opportunities for improvement in your score. We'd love to see you recognize HCM Awareness Day. And we do have some AED placement laws, but we don't have private schools covered in Rhode Island. We would encourage you to include them in your programming and your legislation as we progress. And by taking on some of the concepts that we've laid forth in the Children's Cardiac Safety Act, I'm sure that we can improve this score at least up to a B pretty quickly. So we encourage you to do so, and we will report back at least twice a year to your state legislature as to how you're doing on the report card. So thank you for that. Now we're going to hear from a Rhode Island resident and an HCM advocate. So Matt, why don't you tell us a little bit about your story with HCM and why you find this important to be a part of?
Thank you, Lisa, and thanks to the HCMA for inviting me here today to tell my personal story. As Lisa mentioned, my name is Matt Grant, and I'm a resident of Newport. I'm here today to support the Children's Cardiac Safety Act because I know firsthand how critical early detection of cardiovascular diseases can be. I was diagnosed with obstructive hypertrophic cardiomyopathy at age 25, not because of any symptoms that I was experiencing, but because I had the benefit of regular cardiac screenings due to my family history. Many children, however, are not as fortunate, and without proper screening, they may never know they are at risk until it is too late. My family's experience is a testament to the life or death stakes of early detection. My mother, Shane, was diagnosed with non-obstructive HCM in her early 30s. Today, she is in end-stage HCM, battling severe complications, including life-threatening arrhythmias. She's now on the path to a heart transplant, the only option left to sustain her life. But this disease has already taken members of my family. My maternal grandmother, Patricia LaRue, died from HCM-related sudden cardiac arrest in 1986 at age 42, at a time when much less was known about the disease. My great aunt, Mary Lou Solon, was also one of the first patients in the country to receive a myectomy at the Mayo Clinic, a groundbreaking procedure at the time. And though she survived the surgery, within days she died of a stroke at age 48, another complication often linked to HCM. And the reason I'm here today, and the reason that I got involved in my advocacy and worked with my local state rep to propose the Children's Cardiac Safety Act here in Rhode Island, is because early detection is everything. And there are many personal stories out there. Thankfully, I'm not one of the more tragic cases, but there are plenty of stories out there where just a few days or a few months earlier in the process could have saved the person's life. And like I mentioned in my statement, I was fortunate enough to have a deep family history that led me to be screened early on in life, and led me to be diagnosed when I was. Had I not had that, I probably wouldn't even have known the right questions to ask my doctor. And so that's why the screening is so important. And once one person in your family is identified, it's very easy to suggest to your family members, hey, you might as well get screened as well. Thankfully, in my case, many other members of my family have been screened in recent years, and none of them have been diagnosed with HCM, which is a great outcome.
Fantastic. Thank you, Matt, for sharing your story. Again, we're sorry for the losses that your family has encountered, and we hope that your mom does well, as I am a testament to that, but I'll get to that in just a moment. That treatment does work very well. So what we are seeking in the state of Rhode Island is H5087 has been introduced. And I know that there's been, some movement on this, and there's also some questions and concerns. We want you to know we're here to answer those questions, and we want to make the law work for your state, for your practitioners, and for the children and families that we look to serve. We are happy to have conversations with anybody within Rhode Island legislature that would like to understand better how to implement this in a safe and productive manner. So to all of those who have already gotten on board with us, we thank you very, very much. Representatives Carson, Donovan, Cotter, oh, I'm going to mess up that name, Kazarian, Ackerman, Corvrend, Fogarty, Diaz, Bolin, and Speakman. And if I've mispronounced anybody's name, I greatly apologize. We need to get this passed as quickly as possible so that we can implement it as quickly as possible and have families being able to discuss their own family heart health history. I want to bring everything to a real story, real people. This happened in Iowa. I'm glad I don't have a case per state that I can draw out so clearly. But in this particular case, this young man in the corner here was diagnosed quite young with HCM and had his first surgery back in 2005. The family did not understand, however, that this was a genetic disorder that could impact other lines of the family tree. About 10 years later, his father went on to have open heart surgery in a small hospital in Iowa, and unfortunately did not survive. Actually, I think it was Indiana. He did not survive the surgery. A few years later, the maternal aunt gets diagnosed with atrial fibrillation. And at that point, this gentleman, the first index patient in the family, went and had genetic testing and found the gene, but didn't understand exactly what to do with that information. Dad is no longer here. The bar between the family trees has shifted a little bit, and he didn't know what to do with that data. So put that on the side for a second. 2021, this young lady down here, whose name is Jillian went to a well child examination and was found to be clear, no signs, no symptoms, no family history reported. A year later, though, she went back and a murmur was detected. And that murmur was detected in February. In March, she went on for an EKG, echo, MRI, full evaluation, and her blood was taken because we've done the family history now. And now we know that HCM is in the family and we're looking for something. Unfortunately, the day the genetic test results came back and the plan of action was being set forth for Jillian's care, she came home from school. Her mother informed her the gene was identified and that they were off to a center of excellence to get care. She went upstairs to get ready for work and had a cardiac arrest and died at the age of 17. Jillian, had she had even 6 months more notice about this family history, had somebody talked about family history in 2021, we could have done the testing then, and the ICD would have been implanted in enough time to have maybe saved her life on that fateful April day back in 2022. We want to get to the next Jillian in time. And with your help in the state legislature in the state of Rhode Island, we can do that. If you would like to talk to us more about these laws and why we find them so important and how you can help to activate them, you can set an appointment with Julie Russo, who is our legislative lead here at the HCMA, and she can get you on the phone with myself, with herself, with medical providers. You name it, we will provide you the testimony that you need and the understanding to make this happen. If there are any questions, we're happy to take them now. And while we're waiting for any questions to populate, I would just want to thank you for taking the time of listening and thank our board of directors, our staffing contractors, our volunteers, our partners, our sponsors. And as I mentioned early on, with regards to Matt's mom and I being on a similar path, 8 years ago this week, I was in the hospital recovering from my successful heart transplant. I was born with a family history of HCM and at age 12 diagnosed, and at age 47 listed for a heart transplant. I'm happy to say that's 8 years behind me now, and I'm doing very well. And Brandy is my donor, so I encourage you all to talk about how organ donation may be the right move for you if your family is in that situation. but I am very grateful to my donor family. And now I'm going to stop the screen share and look at our chats. We have some questions there. I don't see any questions in the Q&A at this time. If anybody has any questions, now would be a good time to ask. And I thank you for your time. If anybody has any closing comments, we have 3 minutes and then we hit time. So if anybody has anything they'd like to add, just feel free to unmute themselves. Are there any states that have an A on their report card was asked? And the answer is no, not yet. We have a lot of Bs. We have a B+, but we do not have any As yet because there are elements missing, whether they be access to care through copay accumulator laws or step therapy laws, or if it is AED placement, CPR placement. There are a lot of elements to our report card, and we hope to see a lot of A's popping in the next couple of years.